This, we move to a very important speaker of the inaugural session, Dr. Madan Gopal, Senior Consultant Health, NITI Aayog, Government of India, and he'll be talking on improving health outcomes through policy, technology, and innovation. Over to you, Sri Dr. Madan Gopal. Thank you so much.
Okay, I can remove this now. Okay, thank you very much. Thank you, APAC, for this opportunity to share my thoughts, what we have been doing. One of the technological things we have been always grappling, how we have been able to manage this COVID epidemic. We know that the virus can enter only through your face or that mouth. And what kind of innovation we can have? We can have a barrier that is in the form of mask. I request that we should not allow the virus to enter us till the peace times return back. So only the innovation which has happened is a good mask. We can use this mask when we are not speaking. So that's the way we can prevent this. This is a technological solution for preventing the entry of the virus into our bodies. Another important thing, technological advancement which has happened was the use of sensors during the COVID epidemic. The sensors were in the form of, you have seen that how beautifully we managed the COVID patients in the house, in the hospitals, early detection, and how we have facilitated the home care management of COVID. We have used digital thermometers. Previously, we were not using that. Then we had the pulse oximeters, which has at least raised alarms that the person requires hospitalization. Then we have used the telemedicine guideline. Before coming to my topic, I'm just saying that how the technology and the innovations which have yielded and which has facilitated the management of the COVID quite comfortably. Because if you look at the surge, during the second peak when the surge happened, our systems were overwhelmed and we could not provide beds to the people who were requiring it. The people who were requiring the ICU beds, they have to be managed at a lower level of center. And the people who require oxygen support, we have managed. We have seen that catastrophe and we have seen that surge. We pray that this doesn't happen. But thanks to the technology which was available, and we had made the enabling this policy for enabling the use of technology for management of the patients. When the COVID struck, lockdown was there, and lockdown was as a measure for seeing that if people stay inside, the virus propagation can be stopped. During this lockdown time, what happened that the people, because if you look at the non-communicable disease in the country, we had a load of non-communicable disease, and many people, they require treatment. What will happen to these people if they don't come up for follow-up and treatment? That prompted us to think of having an enabling guidelines, because telemedicine, before this release of the telemedicine guidelines, was illegal in the country, because honorable courts have taken cognizance of that and they have passed orders against the doctors for WhatsApp consultation, telephone consultation. They were all illegal. After the release of this telemedicine guideline, it created an enabling environment, as Mr. Pathak has told, that it's a big billion industry which has been opened up by just small enablement of the telemedicine guidelines. And that has acted as a game changer in the management of COVID during these difficult times. Having said this, I will be just coming to the topic, that is the impact of the policies on the outcomes, innovations, and the other things. World Health Organization was constituted, we have to go historically to understand the perspective, what we are talking about this. If you talk about World Health Organization, there was no consensus on the definition of health. For 40 years, they debated on that. Then after that, everybody knows that disease and the hospitalization, they know the person is not sick. So that definition was there. What is sickness, what is disease, that definition was there. But there was no definition of health. Not to talk about the outcomes and other things. It took 40 years of debate, discussions to arrive at a consensus, the definition which all know, that the Alma Ata Declaration. For achieving that kind of health, that is the state of physical, mental and social well-being, an approach was designed That approach we call as a primary healthcare approach, which has the 8 elements. I am not going to delve into the details of that. But that approach was there. The health for all was given. Health for all means we would be reaching a state of health. That was the imperative, global imperative which was given. The approach was the primary health care. The use of, if you look at the definition of that, that means use of indigenously developed replicable technologies for having a positive outcomes. That intent was there. The policy intent was there in this Alma-Ata declaration. The approach was there. But somehow we could not reach that target. Now the UN body, they set in the Millennium Development Goals with the focus area was, the approach was the primary health care. Then in 2015, with Millennium Development Goals were also, we could not see a good outcome of that. Then 17 goals were set for the Sustainable Development Goal for 2030. The use of technology, the use of primary health care approach that was there is still there. But what we did for achieving this, we are having 2 enabling things. One is the National Health Policy 2017, which has set up targets. That means what could be the outcomes. It has talked about the digital ecosystem in the country for achieving that outcomes and the targets. And it has also set in some aspirational targets so that we, as a commitment to the Sustainable Development Goals, the global community, so that the achievement of that outcomes, they are enhanced and they are achieved. We are having an enabling National Health Policy 2017, and we are having a mechanism of spearheading that thing so that we are having a favorable outcomes. For achieving that thing, we are having a vehicle in the form of National Health Mission and the other program, the centrally sponsored scheme and the center sector schemes, which creates an enabling mechanism for achieving these outcomes. So way back, apart from the achievement of the outcomes, we are trying to see that how we build a system with a focus on primary health care. Then we came up in 2014-15, we came up that we should be having more impetus, more focus on achievement of the outcomes. Then the Ayushman Bharat scheme was launched. It is having 2 components. One is the Ayushman Bharat PMJ, which everybody is aware about that. But the other important component, which is the primary health care and the promotive component, is the Ayushman Bharat Health and Wellness Centers. That means we are now upscaling our approach from primary health care to a comprehensive primary health care. With the primary health care approach, we have created a structure, the health structure, which is district hospital, medical college, district hospital, the community health center, primary health center, the sub-centers, and we are having a fleet of healthcare workers in each and every village in the form of ASHA workers. We call them ASHA workers. At the sub-center, we are having the ANMs or the health worker, male and female, and the PSC. That's the place where first contact with the doctor is there, a medical professional is there. And at the community health center, you are having specialist services are to be available. This was the approach we were having. We are trying to have more packages to be built at the community sub-centers, and that's why all these sub-centers, they are being upgraded into health and wellness centers. Health and wellness center, as we have mentioned, is having a technology component. That means we have to enable a technology there so that a remote consultation can happen in the health and wellness centers. There's a whole ecosystem which is there, which is in the process of development. We're trying to pilot and we see that how it evolves. So that kind of approach is there for improving the outcomes. If you look at the things which we have achieved, we have did considerably better in the achievement of most of the outcomes which have been envisaged in the health policy 2017. But lot more is required. The approach is to be different now with the technology ecosystem which is evolving. So we have to see how we can leapfrog the technology for expediting the achievements and meet the global targets of the Sustainable Development Goals set for India. Having said this, I just come back to the same thing when the Ayushman Bharat program was conceptualized, and then it was thought that we should be having a stack. That means a software was required to quickly roll out the PMJ program, and there was also discussion going on that when we evolve and have our own software, that is PMJ 2.0, which they call, that should be acting as a stack for all the other programs. If you look at the health website, you would be having each program, malaria program would be having their own portal, TB program is having their own portal, the RCH is having their own portal, and the other programs they are having their own portal. That means if I am a beneficiary residing in a particular place, if I am hooked to a malaria program or TB program, my information is collected differently. But this information don't talk to each other, as Mr. Bhushan has told about this. This whole integration process was also started way back in 2011-12 in the form of integrated health information platform, in which all the other portals and other things would be riding on this. Currently, there is a process going on for riding all the other programs onto this platform, so that with a single ID, the person can access all the information. They should be talking to each other. To develop that thing, a concept called that National Health Stack came. And after that National Health Stack, a digital blueprint was made for digital ecosystem for the country, and which is now rolled out as a digital mission. I think Praveen Gedam would be talking more on that if he logs in. So basically, essentially, it is a creation of ID for the patient, a creation of ID for the hospitals, and creation of ID for the provider as well. So basically 3 things. So that if a person is having an ID, all the systems can talk to each other, and you can have a intelligence or the analytics being worked on all these things. That simultaneous work will go on for that as well. You see the tremendous impact how if we are using the digital platform for all these things. Previously, having seen the previous epidemic of H1N1 during a decade back, at that time, interacting with the states was very difficult because that kind of digital platform was not there. Having a video conference with the state was there, but it was not exploited to this much as we have done with the other platforms which are available, the WebEx and the other platforms which are every other week, every other day, the ministry is having a video conference with few set of states. That kind of leverage which we have taken during this epidemic. Second thing which was happened, we have used the technology for managing the pandemic as well. You have seen the use of this, everybody might have seen the COVID India.org, that 19.org, is a crowdsourced platform. You see how they have used the bots and the APIs, how they have designed that thing with a freelancing kind of thing. They have generated a platform. What is happening in South Africa, now you know immediately what is the caseload there. Previously it was not possible. This all are there for our advantage so that informed decision is taken. You see quickly how quickly we have acted this time for having the for revising the international travel guidelines. Previously it was not there. It was very difficult to come to a conclusion unless some evidence is there. There was evidence that surges are happening in the European countries and other places. Now we have to see that if the surges are happening, apart from that the quality of the testing which are there, you see the quality of testing which is happening. We were worried about the quality of testing. I was discussing with Atulji that the NABL is also there. All the NABL accredited laboratories initial phase were allowed to do COVID testing, but still doubt was raised on them. Now all the people who are COVID negative, they have uploaded the certificate on the Suvidha portal, and now they are tested here and they are turning out to be top state. There are few instances that they could be in winter period, they might have acquired infection, but still, you see, if technology is used for things, how things can change. How it has enabled that previously for development of vaccine, it used to take 10 years, not less than 5 years or 10 years. But this time we have made the things possible in 9 to 10 months. So lot of things are there which can be leveraged and we can be using for monitoring that thing. Apart from that, the outcomes, the impact and the outcomes which we are trying to see that can be monitored now. So we are having good equipments. We have developed the Aayog Setu that was meant for doing the surveillance. That means if the person is exposed to a COVID positive patient, because the information is coming from the ICMR portal to that software, and the mobile number is used for tracking that patient. The moment the person, and with the help of mobile triangulation and the Bluetooth connectivity, that anybody who is exposed to that person, immediately the information comes to the command center. But why it has not been that successful, we have to find out the reason, because the information coming to the command center or the center, there has to be people with capacities to analyze that thing and take prompting action. That's the place we have lagged it during the initial part. But still, it's a very good tool. It has shown that how it can be, how the people can do contact tracing, and more or less versions people they have developed during this COVID times. The other is how we have migrated from the EVIN platform, that is e-vaccine, that is the Electronic Vaccine Intelligence Network, which we used to have for monitoring the logistics of the cold chain during our routine immunization. That was upscaled and advanced to in the form of COVID. Initially, it was small modules were there, and as the scope of the things improved. Now you have seen that it is a case study for the other rest of the world. Now we are trying to transfer this technology to other people. It talks about right from scheduling of the vaccination session, logistics management, beneficiary engagement, to the generation of the certificate with a QR code. That kind of things have evolved. You see how it has eased out the things. Otherwise, it is very difficult to have 2.5 crore vaccinations in a day without the use of technology. It's not possible. Previously, working at the district level, we used to, for having two sessions in a week, whole of the week used to be spent there. Now, with the ease of this, in 3-4 hours, you are scheduling whole of the week's immunization sessions. So that kind of enablement has happened, and with the use of technology, with the use of other enabling things which are there. So the outcomes are definitely going to improve. The second thing which we have to think from the device and other perspective is that the population demographics are changing. In 2011, the senior people, that is people above 60 years, was around 8%. In 2021, it is going to be 12, and in the next decade, it will be more. We have to think that how the home care and the other care is going to increase. Home care has already increased, but how there would be demand of home care for these people. If this demand is there, there are some equipments which are required. Equipment for physiotherapies, equipment for this, and how to enable these people to use of the technology, how they can, it's not that they are dependent on others. We have to plan now. If somebody is smart enough, they will plan for them. In the 5 to 10 years, usually takes time. In 5 to 10 years time, you will see that how you have invested now, that is going to yield results. In the last, I will thank again for the APAC for giving this opportunity. So thank you very much. I wish all the success for this.
Thank you so much, Dr. Madan Gopal, Senior Consultant Health, NITI Aayog, Government of India, for giving a detailed journey of improving health outcome by enabling technology and innovation. And you talked about various instances, and taking cue from what you have said, that a famous saying was that sometimes it takes years to change things, sometimes it takes weeks to change things, and that has happened during the pandemic, that how quickly we have shifted our focus to that technological and digital innovation mode for improving our healthcare ecosystem. Telemedicine, we used to talk about, dekha jayega, ho raha hai, but see what has happened in the last 1.5 years. So that is the power of technology, and that is how the monitoring of various things can be done through technology to improve the outcome. That was the crux of what Dr. Madan Gopal was saying. Thank you so much.